So to get started onto our first session, I'm going to turn things back over to Dr. George, who's already kindly introduced himself, so I don't have to lose my breath going all over all of his accomplishments, and he'll give us an overview of Parkinson's disease. I would note that Dr. George has served excellently as the chair for the Michigan Parkinson's Foundation for the past 5 years, and we really appreciate all his efforts in that regard. Dr. George.
Thank you again. Let's see if we can get the slides up here. Okay, so I'm going to give a hopefully brief overview of what Parkinson's disease is and how it takes place to provide a foundation for what the other panel members are going to talk about. So what is Parkinson's disease, and really what happens to the brain in Parkinson's disease? Formally, Parkinson's is named after James Parkinson, who gave the first description of the disease in 1817. He put together all the different symptoms and said this is one condition. But we know that the disease has existed since ancient times by descriptions of symptoms that people had in historical accounts. It is technically a neurodegenerative disorder characterized by the progressive accumulation of Lewy body inclusions along with selective destruction of dopaminergic nerve cells in the nigrostriatal tract of the brain. A real mouthful, so we'll go into more detail about what that means. So first of all, it is a chronic progressive neurologic disease, and it is neurodegenerative. And when we say neurodegenerative, it means there are actual brain cells that are being lost as the disease progresses. Because we can't replace these cells, there is currently no known cure. However, we have a lot of treatment that controls symptoms, usually for very many years. However, the underlying disease continues to progress, and what we're really interested in is neuroprotection, suggested but unproven for a number of medications. And a neuroprotection would be a medication that helps to prevent the further loss of nerve cells. And I'll come back to that in a few minutes. First, some facts and figures about the disease. There's about 20 new cases of Parkinson's disease per 100,000 people per year. There's 120 to 180 out of every 100,000 Caucasians who have Parkinson's disease. The mean onset is between 55 and 60 years of age. That's the most common onset, but it can happen really any time after 30 years of age. It's rare below that, and of course continues to happen as people age. So the prevalence, the total number of people with the disease, increases up to about 2% of people over 65 years of age. 5% of Parkinson's is young onset, that is coming on before age 35, and the overall prevalence varies with geographic areas. So once again, at the base of the thing is the loss of the dopamine-producing nerve cells from what's called the substantia nigra, which is just means the black substance. It's an area that can be seen if the brain is dissected in the brainstem that actually looks black. There's a decreased number of these cells with age in everybody, even without Parkinson's disease. But in Parkinson's disease, the cells are lost much more substantially. And in fact, somewhere between 50 and 80% of these dopamine-producing nerve cells are gone before you even develop symptoms of Parkinson's disease. So dopamine we keep talking about, it's what's called a neurotransmitter. It's a chemical that's released by one nerve cell to signal another nerve cell. We also talk about Lewy bodies, which are seen under the microscope, and they need to be present for a diagnosis of true Parkinson's disease. So what are the basics of the brain that we're talking about with these nerve cells? Nerve cells in different parts of the brain, sometimes referred to as areas, sometimes we talk about ganglia, and they have different roles, and they're connected together in circuits, sometimes called pathways or tracts. Nerve cells form the wiring of the brain. Each nerve cell body extends a long, thin processor extension that carries signals electrically to other cells, often in other areas of the brain. But the connections between cells require release of these chemical transmitters that bind to receptors on the receiving cell to activate it. So here's connections in the nervous system. You can see these, here's a nerve cell body, and then this long, thin extension of the cell that electrically conducts, so we have these little lightning bolts, and then this connection to the next cell, which is where the neurochemical transmitter is released. And the one that's of key interest to us in Parkinson's disease is the dopamine. It's called the synapse, where one cell connects to the other, and it's illustrated here. The electrical signal is coming down from the top of the slide to this button at the end of what's called the axon, and this figure shows that dopamine is being synthesized, manufactured in this end of the nerve cell, and packaged in little packets that are released when an electrical signal arises. Then the dopamine crosses over to the other cell at the bottom of the slide and binds to the receptors shown there in the membrane and activates the next cell. This is where most of our medications work. The best known, levodopa, is one of the basic building blocks for making more dopamine, so you can release more dopamine. Some of our other drugs that you may be familiar with, such as Mirapex or Requip or Nupropatch, are medications that bind to those receptors and help to enhance the transmission of the signal from one cell to the next. Some of the other medications, Azilect and Selegiline, help to prevent the dopamine from being broken down, let it be recycled, let it hang out longer and bind to more receptors once it's released. So I mentioned that this involves connections between one area of the brain or the other. And so this slide just shows, now this is a slice vertically through the brain drawn here. So the ears would be off to either side and the eyes would be sticking out in front of the slide. Right in the middle of the brain, down here at the bottom, is this substantia nigra where the dopamine cells are, and they reach way up to this light blue area, and that's where they release their dopamine. Then these other structures, the basal ganglia and the thalamus, connect from the cortex of the brain, which controls movement, through these areas in loops and back to the cortex to help determine what movements people are going to make. And the dopamine being released modifies these circuits that runs through there. So why do I bring this up? Well, there's something called a DAT scan. Sometimes people think it can be used to actually diagnose Parkinson's. It certainly can be a contributing factor. Here's an actual slide from an MRI scan looking at the brain. Now here the slice is horizontally across so that the ears again are off to either side, but the eyes would be up towards the top of the slide, but a little deeper than this. But you can see right here are these structures that make up the basal ganglia, and here's the thalamus. But the key is the basal ganglia here, where the dopamine is released. And the DAT scan is a nuclear medicine scan where the patient is given a nuclear tracer that is taken up by those dopamine-releasing terminals. So top left, you see a normal DAT scan. All this red and yellow is lit up because the tracer has been taken up by dopamine-releasing terminals. And then as you move over to the right, the next two slices are images from people with Parkinson's, showing that there's far less uptake because of the loss of those dopamine-releasing terminals. And then the final two are from some other Parkinson's-related diseases that aren't true Parkinson's, showing that they also lose those terminals. The slices across the bottom are imaging using a nuclear medicine scan, but in an experimental tracer that actually binds to the receptors. And The main point in putting that in here, the receptors, of course, are in the same places that the dopamine is released. And in the second from the left, you see a patient who has Parkinson's but has not yet been treated. And the brain, in reaction to the loss of dopamine being released, has upregulated the receptors. And that's one reason why you can lose so many dopamine cells before you get symptoms, because the brain does compensate. So the DAT scan's been approved by the FDA since 2011 and can be used to differentiate not Parkinson's from everything else, but different conditions that do or do not have a loss of dopamine releasing terminals. The FDA said, well, it's good to tell Parkinson's from other sorts of tremors, and that certainly comes up. Some people have very confusing tremors. In many cases, a Parkinsonian tremor looks quite distinct from other tremors. But it's not appropriate to do the scan just to confirm that you have Parkinson's if it's clinically definite that you have Parkinson's. And it can't tell the difference between some of the other Parkinson's-related diseases, as we saw in the images of the slides. So what do we mean when we say someone has clinically definite Parkinson's? This comes to the key, the symptoms, which most of you are familiar with. So these are the cardinal motor signs. It said there are 4. I've got 5 bullet points, but 2 of them go together. So one is cogwheel rigidity. It's a change in the muscle tone that can be felt when somebody moves the limb of a person with Parkinson's around while the person with Parkinson's relaxes. So you'll often find neurologists grabbing your hand and twisting it around, moving your arm around to try and feel this change in muscle tone. The bradykinesia and hypokinesia that go together, Greek words meaning slow movement and reduced movement. And this is really the key movement problem in Parkinson's. You go to make a movement, it's hard to get it started, it comes out more slowly than intended, it comes out to be a smaller movement than intended. And that's the key result of not releasing enough dopamine in these circuits that control movements. Also very common is the resting tremor. Classically, it's a slow tremor, 4 to 6 hertz. We talk about a pill rolling tremor because often it looks as if somebody is rolling something between their fingers and their thumb because of the way the tremor acts. Only about 70% of persons with Parkinson's will actually have a tremor at any given time, however. And then the final cardinal motor sign is postural instability, which includes a flexed or stooped posture, but also this tendency to stagger, what we call festination and retropulsion. So I focused earlier on the substantia nigra, where the dopamine neurons reside, and that's where you lose them. It's underlined here. These are the key nerve cells that are lost that cause these problems with movement. However, below them are a whole bunch of other nerve cells that can be affected by Parkinson's disease, not all of which have dopamine as their neurochemical transmitter. And in the other column, you see a whole long list of other symptoms that we commonly have to deal with in persons with Parkinson's disease, many of which are related to these other types of cell loss. So the treatment of Parkinson's disease involves not only managing dopamine and difficulty with movement, but also discovering and treating all these other sorts of symptoms. And it's important to realize that these that we call non-motor symptoms are in fact part of Parkinson's and can respond to treatment in persons with Parkinson's. These are the major medications that are used to treat Parkinson's. Levodopa is at the top. I say levodopa is king. All of the agents in black are used to control movement problems in Parkinson's, not the non-motor symptoms. Carbidopa is familiar. Levodopa in this country is always given with carbidopa to help prevent side effects. You may recognize some of the other dopamine agonists. Which are, again, the drugs I mentioned like pramipexole and ropinirole that bind to the receptors, and then some of the other agents that are used. in blue at the bottom are a couple of drugs that can be used not to really affect Parkinson's, but to affect the body's metabolism of levodopa to keep it in your system longer and get more benefit out of it. Now, using these medications can become quite complex, and here's one example of a flow sheet trying to outline the approach that physicians use, trying to figure out which drug should be used at which stage of the disease according to what's going on with the patient. The take-home message from this, since you're not learning to be neurology residents and treat Parkinson's disease, is that the treatment, even of the motor symptoms, is highly individualized. So management of Parkinson's symptoms is complex, and for each person at each point in their disease, you have to take into consideration the different types, not only of motor symptoms, but also non-motor symptoms, and select the medications and treatments appropriately. So now I'm back to the microscope. Here I am looking through the microscope, and the little cells are looking back up at me and saying, ah, the eye, the eye. Anyway. These are these black cells in the substantia nigra. You can see them in the normal brain. You can see a brain from a person with Parkinson's. There's only one big black cell left there on the right. This is what happens. And as mentioned before, there's something called a Lewy body that forms particularly in the area where nerve cells are being lost. Again, this is showing different sorts of staining under the microscope, but Lewy bodies are these big blobs. The one in the top left is the classic normal sort of staining we do on the brain, the purple and the blue, and you see this big blob that's the Lewy body. But you can see in some of the other stains it's stained gold or brown, and it can be in different cells in different parts of the brain at different times, as shown in the other squares. And that's where it became recognized that these Lewy bodies begin forming deep in the brain stem, which looks dark red and brown in that top picture. But gradually they spread throughout the brain, causing more and more symptoms as things progress. And then back in 2008, people realized that even if you implanted cells intended to replace dopamine cells that were lost, those cells also were contaminated and basically caught Parkinson's disease from the rest of the brain. And this has led to a whole bunch of research investigating how these abnormal proteins form and create the Lewy bodies and can actually spread throughout the brain and lead to the neurodegenerative process. And here's a great title that this alpha-synuclein immunotherapy can block the uptake and propagation of the abnormal alpha-synuclein and thereby block the neurodegeneration. This would be absolutely wonderful if we were talking about people, but this article from a few years back is actually talking about cell cultures and mice. However, it's a step in the right direction. So a lot of the research that goes on now is directed at how we can block this progression of the disease in the brain. And hopefully it is the end of my talk for sure, and the beginning of the end of Parkinson's disease.